The last section we discussed the pathophysiology of heart failure. So in this section we are going to discuss drugs which can be used for the treatment of heart failure. So for the treatment of heart failure, first of all we should know whether heart failure is acute heart failure or chronic heart failure. There are different aims in the treatment of these heart failures. For the aim of treatment in acute heart failure is to treat pulmonary edema, because the main problem in acute heart failure is pulmonary edema, and since there is decreased contractility of heart, so another aim of treatment is to improve the contractility of heart by giving positive inotropic drugs. Now in chronic congestive heart failure, the aim of treatment is to prevent the mortality, because by compensatory mechanisms heart is able to contract. So the aim of treatment in this case is to decrease mortality, which can be achieved by decreasing the compensatory mechanisms which are responsible for mortality. And it can also be achieved by decreasing workload of heart, that's by decreasing the preload and by decreasing afterload. So these are various ways by which we can achieve the decrease in mortality in case of chronic CHF. In this graph, after acute heart failure, the heart functions at point B. So in this case, we need to give positive inotropic drugs so that heart can work at point C, or the curve can shift to the right so that there can be increased contractility of heart. However, in case of chronic CHF, heart works at point D after decompensation. So if compensatory mechanisms go on, there will be the point will shift more towards the right side, and this will lead to decrease in cardiac output. This will further worsen the condition. So we need to shift the point to the left side by decreasing these compensatory mechanisms, which can also be achieved by decreasing work of the heart. So for acute heart failure, the first thing that we are going to manage is the pulmonary edema. So for the treatment of pulmonary edema, the drug of choice that we use is the diuretic, which is called as furosemide. So for the treatment of pulmonary edema, we use furosemide, and along with furosemide, we use IV morphine. So this is a drug of choice for treatment of pulmonary edema. However, if after giving furosemide and IV morphine, if patient does not respond, then we can give vasodilators. So especially nitroglycerin is preferred because it's a venodilator. It will decrease the preload. And if the patient still does not respond, then we use a new class of drugs called as BNP analogs, that is brain natriuretic peptide analogs. So for the treatment of pulmonary edema, we use diuretics, we can use vasodilators, and we use BNP analogs. Now, the second class of drugs that we use are to increase the contractility of heart. So these are positive inotropic drugs, which will help us to increase the cardiac output. Now, these drugs will include beta 1 agonists, which are inotropic agents, that's beta 1 agonists. And since beta 1 agonists, the stimulation of these receptors increase the contractility of heart by causing increase in the cyclic AMP, since they are GS subtype of receptors. This cyclic AMP is then metabolized by enzyme phosphodiesterase. So we can give another class of drugs which will inhibit the metabolism of cyclic AMP. So these are known as phosphodiesterase 3 inhibitors. They will produce same effect as inotropic drugs. So these drugs will also produce inotropic effect. Now let us discuss these drugs in detail. So the first class of drugs that we use in acute congestive heart failure, these are diuretics. Now diuretics, they can be of two types. So diuretics can either be loop diuretics or they can be thiazides. Loop diuretics, they are also known as high ceiling diuretics. Now these high ceiling diuretics, they have high efficacy, however their half-life is low, they have short duration of action. Thiazides, on the other hand, they have low efficacy, that means they are weaker diuretics, however their duration of action is longer as compared to loop diuretics. Now, because of high efficacy and short duration of action, loop diuretics are preferred in the treatment of congestive heart failure. On the other hand, thiazides, they are mainly preferred for the treatment of hypertension. Now, the main loop diuretic that's preferred is the furosemide, which we already discussed. Now, these diuretics, it's important to note that they are used only for the management of symptoms. They do not alter the disease progression in congestive heart failure. They can only be used to manage symptoms, mainly symptoms of pulmonary edema. The side effects of using these diuretics are they cause decrease in sodium levels, that's hyponatremia, hypokalemia, and they can cause metabolic alkalosis and hypomagnesemia. And their effects on calcium levels are different. Loop diuretics, they decrease calcium levels, that's they cause hypocalcemia, whereas thiazides, they increase calcium levels and cause hypercalcemia. Now, their other side effects on metabolism include hyperglycemia, hyperlipidemia, and hyperuricemia. So these drugs, since they increase the amount of uric acid in the blood, so they cannot be used in conditions such as hyperuricemia and gout. Now, another class of drugs which we use in the patients of acute CHF, these are vasodilators. Now, in acute CHF, they are used to treat pulmonary edema. However, they are also used in chronic congestive heart failure, and they play an important role in decreasing mortality. So, they will be discussed in detail in the treatment of chronic congestive heart failure. Another important class of drugs, which is a recently developed class of drugs, they are known as BNP analogs. So, in order to understand the pharmacology of these, we should know something about the physiology of BNP. So, whenever blood volume increases, it results in increased stretch in renal blood vessels and in the atria of heart as well as in the ventricles of brain. So due to this increased stretch in the renal blood vessels, these renal blood vessels, they release a substance which is called as urodilatin. Similarly, atria of heart, they release atrial natriuretic peptide, and the ventricles of brain release brain natriuretic peptide. Now, all these substances, they are natriuretic peptides, and the net effect will be they cause vasodilation, and they also act on kidney and cause natriuresis, and along with natriuresis, diuresis also occurs. So, the net result of these will be decrease in the volume of the body fluid by causing diuresis. So we can achieve this similar effect, since this effect is useful in congestive heart failure, especially in case of pulmonary edema. So this effect can be achieved by giving analogs of these drugs. So Ularitide, it's an analog of urodilatin. However, it's currently under trial and it's not in clinical use. And the analog of atrial natriuretic peptide has been developed and it is used in some countries. This drug is known as carperetide. However, it's not used in India yet. Analog of brain natriuretic peptide is called as Nesiritide. It's an important drug and it's FDA approved for the treatment of pulmonary edema, which is associated with acute congestive heart failure. Now, this drug Nesiritide is a very important drug in the management of acute congestive heart. Now, if we talk about pharmacology of Nesiritide, this is a BNP analog, and the mechanism of action of Nesiritide is it causes vasodilation and it also causes natriuresis and hence diuresis, therefore decreases the volume of the blood in the body. Now, because of decreased volume of blood, there will be decreased amount of payload reaching to the heart, and there will also be decreased extent of pulmonary edema, which will cause decrease in the symptoms of the patient, such as dyspnea, etc. Now, if we talk about the route of administration of Nesiritide, since it's a tide, therefore, so it's a peptide, so it cannot be given by oral route. It's always given by IV route. As it's peptide, it cannot be given by oral route. Now, Nesiritide, after it produces its action, it is metabolized by the enzyme neural endopeptidase, which is present in the body. So the enzyme neural endopeptidase metabolizes Nesiritide, and this enzyme neural endopeptidase is inhibited by a class of drugs. So this class includes drugs such as sacubitril. So sacubitril inhibits neural endopeptidase, and so another drug of this class is icadotril. So sacubitril, icadotril, they inhibit neural endopeptidase and increase the action of Nesiritide. So there will be more diuresis, so it will produce more beneficial effect. So we can give Nesiritide along with these drugs, that is sacubitril and icadotril. Now, Nesiritide produces some side effects such as angioedema, and because of vasodilation, it also causes hypotension. So hypotension is produced because of vasodilation. Now, angioedema is also produced by another class of drugs called as AC inhibitors. So these drugs should not be given together. So Nesiritide is contraindicated with AC inhibitors. It should not be used within 36 hours of use of ACE inhibitors. Now, let us talk about another class of drugs which we use in acute CHF. These are known as inotropics. So as we know, these drugs are beta 1 agonists, so they are all adrenergic drugs. And since beta 1 receptors are GS subtype of G protein coupled receptors, therefore their stimulation causes increase in cyclic AMP. Cyclic AMP stimulates protein kinase, which causes phosphorylation of calcium channels. So there will be more calcium influx, which will result in increased contractility of the cardiac muscle, and therefore inotropic effect will be produced. Now, drugs such as dopamine, dobutamine, noradrenaline, and isoprenaline can be used as inotropics in this case. Now, dopamine, it stimulates D1 receptors, beta 1 receptors, and alpha 1 receptors, so it produces dose dependent action. Dobutamine is specific for beta 1 receptors only. Noradrenaline stimulates alpha 1, alpha 2, and beta 1 receptors, whereas also isoprenaline, it stimulates beta 1 and beta 2 receptors. So all these drugs, they stimulate beta 1 receptors, and therefore they can increase the contractility of heart. Now, if we have a case of congestive heart failure along with acute congestive heart failure along with oliguria, in that case the inotrope of choice that we prefer is dopamine, because dopamine increases the contractility which is required in case of CHF, and it also stimulates D1 receptors in renal blood vessels, which causes their vasodilation and increases the urine formation in the kidney. So since in CHF the and because of oliguria renal perfusion is less, so another beneficial effect is produced, therefore preferred drug is dopamine. If it's only a case of congestive heart failure, then in that case the inotrope of choice is dobutamine, because it's more cardiac specific, it can produce more inotropic effect. Now this cyclic AMP, after it produces its effect, it's metabolized by the enzyme phosphodiesterase, and the action of cyclic AMP ends, that is increasing contractility ends. Now certain drugs have been developed which are known as phosphodiesterase 3 inhibitors. They inhibit the enzyme phosphodiesterase, therefore increase cyclic AMP, and thus they can increase contractility of heart and produce inotropic effect, which is again required in acute congestive heart failure. So phosphodiesterase 3 inhibitors, this class of drugs also produces inotropic effect by inhibiting enzyme phosphodiesterase. Now, so they cause increase in cyclic AMP, but they do not only cause increase in cyclic AMP in heart. Cyclic AMP increases in heart, which increase the contractility of heart, which is required in acute CHF. They also cause increase in cyclic AMP in the blood vessels. Now, blood vessels, they contain smooth muscles in tunica media, and cyclic AMP in smooth muscles, it causes relaxation of smooth muscles. So the net result will be vasodilation in blood vessels. Therefore, this class of drugs, they increase contractility of heart, and they also cause vasodilation, which decreases preload and afterload of the heart. So because of inotropic effect as well as vasodilatory action, this class of drugs, so this class of drugs is called as inodilators. Now this is a very important class of drugs called as inodilators. They produce inotropic effect as well as they are vasodilatory in action. Now the drugs included in this class, that is phosphodiesterase 3 inhibitors, these drugs are amrinone. This drug is also called as inamrinone, and another drug is called as milrinone, which is the preferred drug of this class. Now, amrinone, since it's a phosphodiesterase 3 inhibitor, it will inhibit phosphodiesterase and cause increase in cyclic AMP, which will produce inotropic effect as well as vasodilation. So, inodilatory effect will be produced. However, this drug is not used because of its serious side effect. This drug can cause thrombocytopenia, which is a dose dependent adverse effect of this drug. So it's not used because of this effect. It can also cause other side effects such as nausea, vomiting, diarrhea, abdominal pain, and even liver damage, etc. So this drug amrinone is not used. Now, thrombocytopenia, it's a dose-related adverse effect. Milrinone, it's the preferred drug of this class. The reason is because it's more specific for the enzyme phosphodiesterase, and it has less side effects as compared to amrinone. Now, the milrinone is the drug of choice in right ventricular failure, because in right ventricular failure it will increase the contractility of the right ventricle, which is required effect, and it will also cause vasodilation. So because of vasodilation, it will decrease the pulmonary edema in this case. So it's the drug of choice in right ventricular failure. It is also used in resistant cases of left ventricular failure, and it can also be used in the patients of congestive heart failure who are on beta blockers. So in acute congestive heart failure, if patients are on beta blockers, then we cannot use inotropics to increase contractility of the heart. So in that case, we prefer inodilators, that's phosphodiesterase 3 inhibitors. Now we have another drug in this class. This drug also is an inodilator. However, it has some other mechanisms of action as well. So this drug is called as Levosimendan. Now Levosimendan, it's also an inodilator drug, and it's used when other drugs, that's amrinone, milrinone, when they are ineffective. So in case of ineffectiveness of other drugs, we use Levosimendan. It inhibits phosphodiesterase enzyme and produces inodilatory effect. It also opens potassium channels, and it also increases the sensitivity of myocardium to calcium. Therefore, it makes myocardium more sensitive to calcium ions, and thus increases the contractility of myocardium. So Levosimendan is also used, and it's an inodilator. Now it's used for the short-term treatment in case of acute decompensated cases of congestive heart failure. So these were the drugs that we use for the treatment of acute congestive heart failure.